Learn it again, but feel the beat. In every learning zone, you'll reach the feet. From bliss to riches, you ditch the glitches. Keep it and learning and you flip the switches.
Hi everyone, this is Dr. Karthik and welcome to GAMTpedia. So today we're going to look into anticoagulation and regional anesthesia. This is one of the very common topics that we come across both in exams and also in day-to-day practice. So these are things that we're going to cover in this video. The video is based on the ESRA guidelines, the joint ESRA and ESRA guidelines published in 2022. That'll be the basis for this video. So we're going to look into what are superficial or deep blocks according to these guidelines, and we're going to look into the management of superficial blocks, which is very straightforward. We're then going to look into the classical anticoagulants, which most of us know already, and then we're going to look into the direct acting oral anticoagulant agents, so the newer anticoagulant agents, and these are the ones that are typically more confusing than the older ones, and we have a GAMT for this. So we're going to look into the GAMT for direct acting oral anticoagulants, which is a Toblerone rocket. And we're going to look at what this GAMT stand for. This will allow you to recollect all the relevant information in less than 10 seconds. Now, trust me, it's less than 10 seconds. So keep watching the video till the end and you won't be disappointed. Okay. And also towards the end, we're going to look into some case scenarios. We're going to take 4 case studies and we're going to see how this GAMT can be applied in day-to-day practice and also in exam scenarios. Lots to cover. So sit tight. Hope you enjoy this video. Okay. This video is based on the guidelines from the joint ESRA and ESRA guidelines published in the European Journal of Anesthesia back in 2022. This is the most recent guidelines on anticoagulation and regional anesthesia. So if you want to explore more, go into this article. They categorize the nerve blocks into superficial and deep. The guidelines vary widely between superficial and deep blocks, so it's important to understand the difference. Most of it is very obvious. Okay, so we'll go through them very quickly. So in the head and neck, the stellate ganglion block, deep cervical plexus block, cervical paravertebral block, they all come under deep. Infraclavicular is the only block in the upper limb that's classified as deep block. The rest of the blocks in the upper limb are superficial blocks. Thorax is epidural as expected, and paravertebral, both of them are superficial or deep blocks. None of the blocks in the abdominal wall are deep blocks. They're all considered superficial. And then the lower lumbar, lower back, the typical culprits, the spinal, epidural, proximal sciatic, Peng block, which is kind of a newer block, is again classified as a deep block. So paravertebrals, sacral plexus block, psoas compartment block, quadratus lumborum block, most common blocks, etc. Right. In terms of the superficial block, the one thing that we need to understand is the subtenuous block, which is the blocks people use sometimes for cataract surgeries. That is considered as a superficial block. All right. So this is important because when you go down later, when you look at the guidelines, you'll know there's a big difference between the two guidelines. So this will come in handy. Almost all the upper limb blocks are considered superficial blocks except the infraclavicular. So intrascaleal, supraclavicular, axillary, suprascapular, ulnar radial, meaning they all considered superficial blocks. And same thing, thorax. Most of thoracic blocks are superficial blocks except epidural and paravertebrals. Your serratus plane blocks, serratus spinae plane block, intercostal, interpectoral, pectoralis, all these are superficial blocks. Same with abdomen, right? And the lower limb, so femoral triangle, lateral canal, sciatics, fasciatic block, lateral extension of thigh, femoral genital nerve, cervical nerve, saphenous. So basically the ankle blocks, the blocks that you do for knee replacement surgeries, etc. They all come under superficial nerve blocks. Okay, we're going to quickly look into management in low risk of bleeding blocks, which is the superficial blocks. Very straightforward. There's no need to wait for the anticoagulants to wear off for the superficial nerve blocks. Okay, that's it. Simple. Everything we're going to discuss from here are pertaining to deep nerve blocks. These are the classical anticoagulant drugs, and the duration that we have to wait. Aspirin, so the typical dose of aspirin used in Europe is around 75 milligrams, which is the regular dose, just kind of low dose, and you don't have to stop aspirin. You can continue, right? You can, any dose less than 200 milligrams, you can continue. Higher dose, you need to wait for 3 to 7 days. Clopidogrel, again, the range given in your ESRA guideline is 5 to 7 days. Okay, warfarin, 5 days, so you all know it, and you also have to have a normal INR. A bit of clarification about the INR and warfarin. So the normal INR range is 0.8 to 1.2. Okay, when you look into the text of the guidelines, it says less than 1.5 INR, which is 1.4 or less, is acceptable as per ESRA guidelines. But they do highlight, however, when they look into Nordic guidelines for neoaxial blocks and also the Scandinavian Society of Anesthesiology and ICU guidelines, they're much more liberal. For the spinal, they have 3 different guidelines: 1.4, 1.8 and 2.2, and that is based on weak, strong and vital indications for neoaxial blocks. And for epidurals is 1.2, 1.6 and 1.8. Okay, so as per the ESRA guidelines, the INR should be less than 1.5. Okay, but it's important to know that there are other guidelines which are a little bit more liberal, so you just need to use your clinical judgment while deciding on what course of action to take. Low molecular weight heparin, if they are on prophylactic dose, which is low dose, you need to wait for 12 hours from the last dose to do neuraxial nerve blocks. If you're using high dose, therapeutic dose, you need to wait for 24 hours. If the creatinine clearance is in 30, remember this 30 is going to come back again later, you need to wait for 48 hours, almost double the time. So, okay, so when the creatinine clearance is very much impaired, especially low molecular heparin, your duration almost doubles. Unfractionated heparin, we don't use it very commonly, but sometimes it does get used. When it's used in low dose, the duration is 4 hours. When used in high dose, the duration is 6 hours if it's intravascular, 12 hours if it's subcutaneous. You need to have a normal APDT as well if somebody is on high dose, especially on infusion. This is very clear, this is very obvious. These are the drugs that we're used to, right? The confusion arises with the direct-acting oral anticoagulant agents, the neuroanticoagulant agents, which are rivaroxaban, epoxaban, apixaban, dabigatran, how long do you wait, etc. It always comes up. But when you look at the guidelines, it can be quite overwhelming. And they look at high dose, low dose, they look at the creatinine clearance, etc., etc. So it's very difficult to remember all this stuff. So thankfully, we have GAMT. GAMT stands for glyph-assisted memory technique, phenomenal memory technique, and specifically designed for high-stakes examination. I've been using this myself for the last 20 years, and it's phenomenal. And strongly encourage you guys to try it. If you haven't watched my previous video, please do go and have a look, and please don't forget to subscribe to the channel. It's very useful. It's going to save you a lot of time. It's going to change the way you learn forever, so it's well worth having a look. Okay. Before we jump into the GAMT, we need to look at the concept. So there are three things that you need to ask when somebody is on direct-acting oral anticoagulant agent and you want to do a neuraxial block. The first is what type of drug this patient is on. Two groups of drugs here: factor Xa inhibitors, which include rivaroxaban, epoxaban, apixaban. Those are all the Zabans or factor Xa inhibitors. It's 10A. Okay, it's easy to remember. And then you have dermatomin inhibitors, for example, is dabigatran. Okay, so first you need to know what type of drug the patient is on. Secondly, you need to know what's the dose that they're on. Are they on low dose of these agents, or are they on high dose of these agents? How do you know? Each drug has different doses. It can be slightly trickier to remember the dosage. So if you're not using it, or if you're not prescribing to patients on a regular basis, the easiest way to have an idea about the dose is look at the clinical indication for which they're prescribed the drugs, right? If they're prescribed for stroke prevention in non-valvular atrial fibrillation and for acute venous thromboembolism, which is usually less than 3 months, so they are usually on high dose. And if you're any doubt, obviously you need to go back and check the doses again, okay? If they're using it for venous thromboembolism prophylaxis after major orthopedic surgery, or if it's for extended prevention of DVTs after 3 months, or acute coronary syndrome, or prevention of atherosclerotic events in symptomatic peripheral artery disease. This is groups of patients, if they are anticoagulant agents, they're most likely to be on lower dose anticoagulant agents, okay? The indication kind of gives you a very good clue, right? Okay. And then you look at the creatinine clearance. How do you calculate the creatinine clearance? You use Cockcroft-Gault equation. So you put in the age of the patient, the weight of the patient's serum creatinine, and for females you need to multiply by 0.85, so you get an output which is the creatinine clearance. Okay. Once you have these three details, you can then use the GAMT to see how long you have to wait before you do a neuraxial block. Okay. So we have a GAMT, which is, we have a rocket launcher. That's the GAMT we're going for, with direct-acting oral anticoagulants and neuraxial blocks. As I told you before, neuraxial blocks means all the deep blocks, okay? Now, so it's not any rocket, this is a Toblerone rocket, right? Fabulous, fantastic. So there's Toblerones everywhere in this rocket if you look closely. So you have the rocket here, and then you have the Toblerone symbol in the middle, 3 Toblerones, 1 Toblerone here, there's Toblerones on the floor. This is a lovely rocket here, fabulous. And there's fire coming out of the rocket, and then you have the huge fumes coming out of the rocket as well, okay? And then you have the stand which holds the rocket, and this is the part that actually attaches the rocket to the stand before it takes off. All right, okay, hope it's clear. If you remember this GAMT, right, you're going to remember everything that you need to remember for direct oral anticoagulants and neuraxial blocks. Okay, it's that simple. It's never been this easy. Okay, let's see what this means. So first we're going to look at the low dose anticoagulants. So you have somebody on low dose, right? So you see this part of the rocket. There are 2 sides, one side here, the other side here. So that stands for number 2, stands for 24 hours. And then you have the base of the rocket here, which is 4 sides, which stands for 48 hours. Okay, so 24 hours, 48 hours. Clear so far? Okay, so with rivaroxaban and edoxaban, you need to wait 24 hours before the last dose. This is for low dose again, before you do a neuraxial block. Okay, and for dabigatran, you have to wait for 48 hours. Right, so rivaroxaban, edoxaban, dabigatran. What's the Toblerone in the middle stand for? Tell you that now. So there's 3 sides, right? So the Toblerone in the middle has 3 sides. That stands for 36 hours. That is for apixaban. So rivaroxaban, edoxaban 24 hours, apixaban is 36 hours. So what are the 2 small Toblerones here? So there's another 3 here, another 3 here. If the creatinine clearance is less than 30, all right? If the creatinine clearance is less than 30, you need to wait for 30 hours for both rivaroxaban and edoxaban. All right. So again, just summarizing, for rivaroxaban and edoxaban is 24 hours if the creatinine clearance is more than 30. If the creatinine clearance is less than 30, it's 30 hours for rivaroxaban, edoxaban. Apixaban is 36 hours irrespective of the creatinine clearance. And again, we're talking about low dose drugs, right? And then if they're on dabigatran, you need to wait for 48 hours. All right, all clear? Great. Now we're going to go to the high dose. So somebody is on high dose of these anticoagulants. How do you know whether they're on low dose or high dose? If the indication is for stroke prevention, atrial fibrillation, or for treatment of acute thromboembolism within less than 3 months, they're most likely to be on high dose anticoagulants, and you need to assume that they are. And if you're in any doubt, go back and check the doses, obviously. All right. Now, if they're on high dose of anticoagulant agents, then it's 3. So the fire coming out of the rocket resembles the letter 3, stands for 3 days. So it's 72 hours. So 3 days. You need to wait for 3 days. If somebody is on high dose, whether they're on rivaroxaban, edoxaban, or dabigatran, or apixaban, any of these agents, whether it's 10A inhibitors or direct thrombin inhibitors, you need to wait for 3 days. 72 hours, the minimum period. Okay. Now, one caveat here is if the creatinine clearance is less than 50. So where is the fire coming from? You see the gas coming out, the fumes coming out from the rocket resembles the letter F. This stands for 50. If the creatinine clearance is less than 50, and if they're on direct thrombin inhibitors of high dose, then you need to do a lab test before you proceed to do deep neuroaxial blocks. Okay. If the creatinine clearance is less than 30, so 3, where does the 3 come from? Is the toblerone here on the base. Okay. If the creatinine clearance is less than 30, and if they're on direct 10A inhibitors, you need to do a lab test. Okay. What's the lab test you're going to do? That's where you have the rocket holder for. Okay. So again, look at here in the top. There's a toblerone here, which is again 3, which is 30. So this is less than 30 nanogram per ml. So that is the drug level of both direct thrombin inhibitors and direct 10A inhibitors. Both these group of drugs, thankfully, has the same concentration below which is actually safe to proceed with neuroaxial blocks. Okay, and that is 30. So less than 30 nanogram per ml. That's both for direct thrombin inhibitors and for 10A inhibitors. Okay, stand here. This is number 1, so that's 0.1 international units. That's anti-10A levels. So 0.1 international units per ml. So anti-10A levels should be less than 0.1 international units per ml. This is for direct 10A inhibitors. Okay, this that holds the rocket to the rocket launching pad stands for letter T. And that stands for thrombin time. Okay, so that is used for direct thrombin inhibitors. For factor 10A inhibitors, you have 2 tests. The first is the drug levels, which should be less than 30 nanogram per ml, and the anti-10A levels, which is less than 0.1 international units per ml. For direct thrombin inhibitors, we have 2 tests. The first is thrombin time, and the second one is the drug levels, which should be less than 30 nanogram per ml. Okay, so there you go. Everything that you need to know about direct acting oral anticoagulants and neuroaxial blocks, or performing any deep nerve blocks in terms of time duration. Everything is covered in this single GAMT. This toblerone rocket is all you need to know. You never have to forget this again. You never have to run back to go look at the guidelines once more again, search which guideline to use, etc. So it's all in one place. Now we're going to look into how we're going to apply that to in a day-to-day practice. So we're going to take 4 examples and we're going to go through them very quickly. On Monday morning, so you have a 74-year-old gentleman for hip fracture as we're holding bay. The patient is on Xarelto, rivaroxaban 10 milligrams BD for atrial fibrillation. So last dose taken on Saturday night at 8 p.m. Creatinine clearance of 35. So when can you do spinal? What investigations can you do to go ahead with the neuroaxial block if you had to? All right. Okay. So let's fix this. So Xarelto 10 milligrams. The indication is atrial fibrillation. So he's on Xarelto, rivaroxaban, apixaban is a direct 10A inhibitor. That's number 1. Is he on low dose or high dose? Is for atrial fibrillation prophylaxis, so most likely high dose. So if you're in doubt, always clarify before you make assumptions. Okay, so atrial fibrillation most likely high dose. Last dose taken on Saturday night is 8 p.m. So he's arrived to the theater on Monday morning. So it's like Sunday night is 24 hours, another 12 hours, so 36 hours since the last dose, and the creatinine clearance is 35. So let's go back to the toblerone rocket, right? So here is somebody who is in a high dose, right? So when they say high dose, straight away 3 days here, right? So that's the default. This is less than 3 days, 36 hours. You can't really do a neuroaxial block. And also you should look at the creatinine clearance. The creatinine clearance is 35. So and the patient is on target 10 inhibitors. So if the creatinine clearance is more than 35 and it's on target 10 inhibitors, there's no need for additional lab test. Okay, so next example, on Monday morning again, the 74-year-old gentleman treating for hip fracture as in holding bay, patient on dabigatran this time, 150 milligrams BD for recent venous thromboembolism less than 3 months ago. So what type of drug is the patient is on? Patient is on direct thrombin inhibitor. All right, dabigatran. What dose is high dose or low dose? So it's 150 milligram BD for recent venous thromboembolism. So these are two indications we saw earlier: atrial fibrillation and recent venous thromboembolism. They most likely been high dose. So let's say high dose. Okay, again, high dose, though, straight away the answer is 3 days, right? Okay, now and the creatinine clearance is 35, right? And last dose taken on Saturday night at 8 p.m. So Saturday night 8 p.m. again is 36 hours. So it's been 36 hours since last dose. Creatinine clearance is 35, right? So when can you do a spinal anesthetic? Now, normally you would say 3 days, right? So because in a high dose, right? But in this particular case, it's not only 3 days, it's also the creatinine clearance is only 35. So you remember from the GAMT, if the creatinine clearance is less than 50, for somebody who's on drug thrombin inhibitors, which is this patient, you need to do additional lab tests. So what are the additional lab tests you need to do? You do thrombin time and also the drug levels. So you can do either or. So the thrombin time is relatively easy than most of the labs. You can ask for thrombin time, and if it's normal, you can go ahead and do a block. If it's not, you obviously can't do a block, right? Is it clear? So a lot of things depends on the dose that the patient is on. Let's take another 2 examples. Again, Monday morning, 75 gentleman should have hip fractures and holding bay patient has roxaban 2.5 milligrams BD for symptomatic peripheral venous disease. Last dose taken on Sunday morning at 8 a.m. Creatinine clearance of 20. Now, slightly different parameters here. The patient is on drug 10 inhibitors. Okay, the patient is most likely on prophylactic dose. Okay, so it's not for atrial fibrillation, it's not for acute venous thromboembolism, it's for peripheral venous disease, so mostly prophylactic. So it means it's low dose. Okay. Right. Okay. So low dose rivaroxaban. Then you go back, and then what's the creatinine clearance? Creatinine clearance is a bit low. Creatinine clearance is 20. Okay. Let's go back. So low dose and rivaroxaban, right? So low dose and rivaroxaban. So low dose and rivaroxaban is 24 hours, unless if the creatinine clearance is less than 30, is 30 hours for rivaroxaban and edaxaban. Okay. This patient's creatinine clearance is 20, which means it needs to be 30 hours. Alright, so you need to be 30 hours. The patient is on low dose of direct 10 inhibitors and the creatinine clearance is less than 30. You need to wait for 30 hours from the last dose. The last dose is Sunday morning 8 a.m. So Monday morning is 24 hours. You need to wait around 6 more hours. So you probably can do it around 2 o'clock, 1400 is when you can do a spinal anesthetic. Okay, hope that's clear. So that's kind of how you use the GAMT. When can you do spinal? You can do it 1400. What investigation can you do to go ahead with the neuroaxial block? If you can't wait for that long, if you want to go ahead and do the neuroaxial block, obviously, because 10 inhibitors, you can do 2 tests here. One is the lab values of drugs from inhibitors, the lab values of drugs, which is less than 30 nanograms per ml, or you look at the anti-10A levels, which should be less than 0.1 international units per ml. Alright, so the last example, Monday morning, 74-year-old gentleman scheduled for ORF for periarticular hip fracture, arrives in the holding bay, patient on dabigatran, 150 milligrams OD for DVT prophylaxis, last dose taken on Saturday morning at 8 a.m., creatinine clearance is 55. So what stuff you have here? Patient is on direct thrombin inhibitors, dabigatran. Is he on high dose or low dose? Patient is for DVT prophylaxis, so most likely it's a low dose. So atrial fibrillation and therapeutic anticoagulation for acute venous thromboembolism, you probably be on high dose. Prophylaxis usually low dose. So let's say low dose. Okay, and low dose direct thrombin inhibitors, straight away when you look at the GAMT, when you remember the GAMT, it's the base here, which is 48 hours. For low dose, it's 48 hours for dabigatran. So you need to wait for 48 hours, right? So we already got the answer. It's 48 hours. Creatinine clearance is not bad either. And the last dose is taken on Saturday morning at 8 a.m. So Saturday morning 8 a.m., Sunday morning 8 a.m., Monday morning 8 a.m. So it's actually 48 hours already. Okay. When can you do spinal? You can do spinal straight away. What investigation can you do to go ahead with neuroaxial blocks? You not show the timings, and the patient is on drug thrombin inhibitors. The 2 investigations you can do as is already. So one, you can use drug levels, which is 30 nanogram per ml, or you can use thrombin time, thrombin inhibitors. Okay, there you go. So this GAMT is really a fantastic tool. It condenses all the information in such an easy, memorable way, and this technique is very easy to use in day-to-day practice. It's very easily scalable. You can actually use it for the entire syllabus, for the entire examination, for any high-stakes examination. We're also developing an app at the moment, probably be available in the next few months, so I can't wait for that to be released. So there is a specific GAMT recall strategy that you need to apply. I put a video on the YouTube as well, so you can have a look at that as well when you get a chance. So it basically involves in the first 24 hours, when you learn a new GAMT, you need to recall it as many times as possible. Mental recall, so just when you're walking, when you're having a shower or brushing, you just recall this GAMT as many times as possible for the first 24 hours. The next 7 days, you have to try to recall at least once a day, all right? And from then on, ideally you should recall it once every week. So first day, next 7 days, and every Sunday. That's an easy way to remember this. First day, as many times as possible. Next 7 days, at least once every Sunday, then you recall again, okay? So there you go. Hope you enjoyed it. And there is a shorter version of this video as well. So for people who just want to look at the GAMT or just want to revise the GAMT flow, there's a 3-minute video that I'm also going to release along with this. So that only covers this particular GAMT, okay? So all the best. Again, don't forget to subscribe for the channel. Please keep the likes and the comments coming, and I'll meet you again in the next one.
Learn a game that feel the beat. In every learning zone, you'll reach the feed. From bliss to riches, you ditch the glitches. Keep it under learning and you flip the switches. Learn a game that feel the beat. In every learning zone, you'll reach the feed. From bliss to riches, you ditch the glitches. Keep it under learning and you flip the switches.